Today with Dr. Dan Morhaim, who is an MD, medical doctor, and he's the author of the book Preparing for a Better End. And he is a really interesting, passionate individual. And I know that this is going to be a really great discussion today, because I had a peek at his PowerPoint, and I saw that he's going to talk to you a little bit about his background. So we're just going to ignore the, hey, Dan, let me get to know you a little bit better that I usually do. But if I can welcome Dan to the stage, and now I'm going to embarrass you, Dan, because I was looking up your book, and because I know it's going to be one of the first questions, how do I get the book? And so I did a little Google search, and you are one of the few people that I know that has their own Wikipedia page. Look at that, folks. That is, you have to be have quite an list of accomplishments to have your own Wikipedia page. They just don't. They make that kind of difficult for good reason. So, Dan, welcome. And I know, as I told the audience, that you're going to give us a little bit of your background on the PowerPoint that you're going to share. So I say we just jump into this discussion. What do you think?
Yeah, let's jump in. Look, I understand this is a challenging topic, but this is going to be the upbeat, empowered view because of something that affects all of us. So we can put our heads in the sand, or we can deal with it. So I'll jump to the slides. So I'll do share screen here.
And then while you're doing that, I just want to remind you that, Dan, if you want to take a couple of little breaks and check in with me, I will let you know if there's any questions. And if there is a burning question that I see come up on my radar, I'll just kind of pop in.
Okay, so this is the topic. There's the website for the book. I will cover a lot of things in the book, but there's no way I can cover everything. So books available from the usual sources. But my career, ER doctor, doing shifts, big hospitals, trauma center in the middle of Baltimore. Also worked on Navajo Indian Reservation, volunteered at a homeless clinic overseas, Saudi Arabia and Kuwait after Gulf War I and other places. I was also an elected politician for 24 years in the Maryland State Legislature. And in Maryland, it's a part-time legislature. So my life for 24 years was a legislative session, January to April, and the rest of the year working like a doctor, like everybody else had their own job. And I got interested in this issue for a variety of reasons. So, and of course, I dealt with a lot of things as a state legislator, not just healthcare, and then my Hopkins faculty appointment. So this is just a little disclaimer. Check with your own people before doing anything. Here's the book, and I'm proud to say that it had some great endorsements. Maya Angelou, a couple of U.S. senators, Ben Carson even, and a whole bunch of other folks from across the business, faith, medical communities. So the book is really designed to be practical and readable. Here's the kind of things that can happen and how you might want to deal with them. And I know it's a hard topic. Look, it wasn't, I don't even like talking about it so much, but this is about facing something and doing it in a way that shifts the likelihood to your own values. But to start, a little audience participation, something for you to consider. And of course, I can't see you raising your hands, but let's just run through these. And I won't read too many of the slides because you can read them. But have you been present when somebody took their last breath in real life? And when I ask questions to audiences of this, it's usually maybe half or a third of the audience. Most of us are actually cut off from this universal experience. For me, it was only one time when my stepfather died. Have you completed your own advance directive? That's one of the punchlines here. But also number three, maybe you have, but have you asked everybody else you know to do the same? And number four, when the end of your life comes, last hours, days, minutes, where would you like to be? Who's around you? What's going on? That's a 5-second mental exercise for you. So I'll give you 5 seconds to think about that. Okay, did anybody say killed in a fiery car crash? Anybody say injured in a drowning accident? No. Anybody say, oh yeah, in an intensive care unit, long past any hope of recovery, in a coma for weeks at a time, tied to monitors with tubes and everywhere, and with my family down the hall. No, we didn't say that. Now, let me be clear. I want the best of modern medical care. But when the end comes, that's not where I want to be if I have a choice. And so what most of us say is some version of at home with my friends and family around me, pain-free. What most of us fear, we can't do anything about death, but it's the run up to it. And most of us fear isolation, dependency, and pain. And all of those can be well managed for no money, for free. All services if we just take advantage of them. So this is how most of us operate in our minds. We are in a state of denial. But this is me being an ER doctor, and I work day shifts, night shifts, weekends, holidays, taking care of anybody and everybody that came in. And then you see this procedure, which I had ordered or did on many people, and it's a cardiopulmonary resuscitation, which on TV has a great resuscitative record. 80% people come back, but in real life, and I was the guy that did these procedures or this procedure, putting in central line large bore IVs into the jugular vein, the subclavian vein, or in the femoral vein in the leg. And I would often wonder, what exactly am I doing? This person has no chance of survival or meaningful survival, even if I can get their heartbeat back for a while. So it got me curious about this whole issue of advanced care planning, because and when we do these procedures, I'll give an extreme case, a 99-year-old patient who's been demented in a nursing home with tubes and contractures all their arms, and they come in and then we do full CPR for an hour or half an hour because nobody made a decision. And you feel the ribs crack when you push on the chest. Now, I do like being an ER doctor because we did take care of everybody. And, you get to meet all kinds of people. It's amazing. It's an amazing experience. I didn't like Saturday night shifts, 11 to 7, but that's part of the job. On the other hand, some Tuesdays and Wednesdays, I was off work and could go to my kids' school. But we're all part of some work in some big system. There's always big systems running things. So the systems manipulate us and we are manipulated by the system. And how do we manage that? This is one piece of advice that I would advise everybody to do. One of the things nobody has on their to-do list for the day. Let's see, pick up the dry cleaning, get the kids, go shopping, and go to the emergency room, either for yourself as a patient or a family member. But if you're the patient, the first thing we ER staff have to do, doctors, nurses, physicians, assistants, clerical staff, is find out who's in front of us. And we can't always get all this history. So if there's one slide I really want you to look at, just print this out. I have it by the front door. My wife has hers by the front door. If anything happens, we grab this on the way to the hospital or in an ambulance and say, here, read this. And this will provide the key information that a clinician in an ER knows, gets and knows what to do with you. Well, this is me in the state legislature. I got interested in local politics, ended up running for office, and got elected 6 times. So 4-year terms here in this state. Here I am speaking on one of my bills. I had a lot of bills pass, and see all those green lights. This one passed unanimously. In fact, of my 139 bills that I was the primary sponsor, all had bipartisan support. I am a Democrat, to be clear. But I got interested in this issue of advanced directives. So I asked my graduate student and faculty at Hopkins friend Keisha Pollack, who's now Keisha Pollack Porter and chair of the health policy department at Hopkins, how many people have completed advanced directives, living wills, medical power of attorneys? And she went and came back, and after doing some homework said, well, nobody ever has tested that, looked at that, which told me something, 2 things. One, this taboo about talking about end-of-life care was so profound that even the public health world hadn't looked at it. And secondly, I could get a grant and do the study. So we did. This is a peer-reviewed published study. And what we found is that only 40% of Americans had taken advantage of this free legal service available. And there was about half that in the minority population. And we were the first to identify it as a minority health disparity in another article. And we asked people, if you don't have one, that's 60% of the population, adult population in this survey, and it was statistically accurate. Would you want one? And 90% said yes. So 90% to 60% is over 50. And that got me started between my medical experience in this on a crusade to get people to start completing advanced directives. So, Steve, you want to see if anybody has anything to say at this point?
Oh, yeah.
That we should deal with.
And actually, we do have a few things. Well, everything's on topic today. Well, let's, okay, we
Okay,
got,
I can run through this.
no, this is a good
Okay.
one.
Okay.
Uh, Gary asks, what is your definition of a good death?
I think that's a personal decision. And for me, it's at home, family and friends around, pain-free. And I'll get into some of the other options when I get to part 3 of the advanced directive, or I could do it now. I'm personal. I'll share my parts of my advanced directive. It also says, I want control of the remote. Here's the kind of music I'd like to hear. If I'm having pain, I want vodka and medical cannabis. I want to be taken outdoors as much as possible. That kind of thing. Now, if I get chest pain during this call, Steve, please call 911 in my neighborhood. But if I'm dying of stage 5 pancreatic cancer, I don't want to be in a hospital suffering in an ICU in a septic shock death, which I have seen. So it's a personal decision. And all of this is about trying to give you the options so you can choose. So the
Great.
first thing you choose is, who do you trust? Who do you take to make decisions if you can't? If you're making your own medical decisions, you're communicating with your clinician about what you want. This all becomes operative when you can't, whether it's a temporary or permanent condition. So I will tell you candidly, I have 3 adult children and my wife. So first it's my wife, and then it's the 3 adult children. But 2 of them, we're pretty much on the same wavelength. They're all good people, but the third one, we're just not quite in sync. And that's okay. It happens in families. And so it says, if my wife isn't around, then the 2 that we understand each other well will be involved. I also say in mine, please call my friend from medical school, not to make decisions, but to provide some medical advice. But you can put anybody in there you want. I could put Steve. Steve could put me. It's who you trust and who you're willing to have a discussion with. The second part of the advanced directive is, and it doesn't always go in this order, but this is how I present it, is what kind of care do you want? And there's 3 options: the full court press, the middle path, or let nature take its course. And I like the term allow natural death. As a clinician, I never liked DNR, do not resuscitate, or no CPR, because I never quite knew what was not to resuscitate. IV fluids, a little bit of oxygen. So I like the term A&D, and a lot of hospitals have begun to take that. This is the situation you don't want to be in. And, this is the lifeguard sitting around and somebody's flailing for help. What should they do? This is what's going on, in effect, in hospitals around the country. People are brought in. This is every hour of every day. And people are trying to figure out who they are and what did they want? What kind of care should we provide? I'd rather be directed. People's values, and I go into the book, may be different than mine, but if it's theirs, I will do my best to respect that. So these are, interesting discussions to have, and you have to figure that out for yourself. But let's look at each. The full court press is everything. And at times it's appropriate, and other times it is not. It's appropriate if there's a cold water drowning, because people can survive cold water drownings and have full recovery if they've been underwater. Even in a resuscitation may take a couple of hours. But at other times it's completely inappropriate when you know that death is imminent. But so it depends on your situation, and you will update this from time to time as you complete your advanced directive. Then on the other end, allow natural death. Hospice and palliative care should always be obtained early. It's interesting. So there was a study on palliative care, which is not always end of life, but it's sort of comfort care and planning and supporting families. And it was people who had lung cancer. So they took this group of people who had identical lung cancers. This was the New England Journal of Medicine, and divided them in 2 groups. They got the same treatment. One got early palliative care, the other did not. The early palliative care people lived longer, spent less money, and had a better quality of life. That's a medical trifecta: lived longer, spent less money, better quality of life. But too often in the clinical world, it's changing. Palliative care, people get called, like sort of a clinician, well, throwing in the towel. We don't know what to do with this patient anymore. Let's call those folks who deal with it. Similarly, hospice is, if you are in the last 6 months of life, but the average, and you've paid for it in your Medicare taxes, or those of you who are paying taxes are paying for it for me, thank you, if I get to that stage, if and when I get to that stage. But you get 6 months of care. The average length of stay in hospice in the United States is 2 weeks. So why are we not taking advantage of everything that we've paid for? And hospice does a lot of other services besides what you might traditionally think, and can support families in all sorts of ways. And I'll just give you one example. There was a hospice patient who was still mobile, and he was in his 90s, and he wanted a skydive, and they arranged that for him. So he had a skydive and survived quite nicely, and then went on, to die a few weeks later. So there's a lot of things here that I can't touch on in detail, but really if I got a bad diagnosis today, even like, let's say, lymphoma, and even if I knew that I had 6 years to live or 10 years to live, I would check into hospice and palliative care now. The last thing you want to be doing is trying to figure these things out when you're sick. You want to do it when you're well. But this is what most of us choose, the middle path. If I'm okay and kind of, checking in on what's going on, aware, then keep me going. But if I, get worse and there's a serious life-threatening illness arise, then maybe it's time to let me go. Despite everything, there are situations that are just not manageable, and the dementia Alzheimer's issue is really challenging. And in the book, I do have a dementia advance directive where if you have the first signs, but you're not incompletely out of it, you can fill it out then and then have it be apply. And I was not a Ronald Reagan political fan, I'll be honest, but I appreciate that he was candid about his Alzheimer's, and Nancy suffered from breast cancer and spoke about it. Other people did. And, these are issues we do not talk about very often. So it's good that we're actually able to have these discussions now. And let me tell you too, as an elected politician, I'm out there doing community meetings, and I go through the usual political events of the month and whatever, legislative session reports. And then I'd say, and by the way, I'd like to talk about your death, the death of everybody you know, and please don't forget to vote for me in the next election. My colleague said, "Are you crazy? You'll never get reelected if you keep bringing up this death thing." I said, "No, I think it's important. I'm a clinician. I'm a legislator. I want my constituents to be empowered. That's what this is about." And what often happened is people came up to me and said, "Thank you for bringing this up. I had nobody ever talks about this, and we're going through this right now with my family." So, the voters supported me, and this turned out to be a pretty good thing to do. And I always appreciate the people who were able to break down the barriers to discussion of these hard topics. It's not just for old people. These are all women under 30. And I will tell you, and some of the names will sound familiar because these were big medical legal cases, but no one's ever prepared when they're young. When my kids turned 18, Daddy gave them advance directives to complete. Now they've gone on in their lives and their circumstances have changed, married and so forth. And so they've adjusted as this went on. But young people get in trouble with severe trauma accidents, drug overdoses, or strange things like a subarachnoid hemorrhage, which is bleeding inside the head. And so this is important for everybody at every stage of life. Now, this slide reminds me that we have to talk about costs. We can't talk about medicine without talking about costs and the financial aspects. But the main reason to do this is empower so that when the situation comes up for you, your values are respected. You tell your clinicians directly or through the advance directive or through your surrogate decision maker who you trust, what kind of care you want. And you can't anticipate everything, but you can do a lot. So most of the money we spend in our lives is spent at the end of life. And there's different ways to look at that number. 30% of all the healthcare dollars we spend in the lives are spent in the last few months of our lives. And so, is that really the appropriate thing that we want? This is another slide that does the same thing. So we often end up raising money for healthcare with doing things like this. I run in charity 5Ks. I'm old, but I'm still able to do that. So I'm sensitive to this particular slide. But there is a Medicare financial crisis coming on. And I wrote this article. It was Michael Smerconish, if you know, he is CNN guy. And the fixes are always financial. But if 95% of Medicare patients completed their advance directives and they were available, which is another question, and applied by, which is another question, by clinicians, let's say conservative estimate, and people took care of hospice and palliative care early and had their pain and other problems managed, they could save 20% of that $250 billion, which is how much money of Medicare's $900 billion is end-of-life care. That could be $50 or $60 billion. And that would be achieved by expanding and respecting people's choices. And how do we usually manage healthcare costs? We create a system that nobody can understand. We put burdens on taxpayers. We put burdens on employers. We put burdens on employees. And a lot of people are making a lot of money, and a lot of the dollars don't actually go to healthcare. unfortunately. So this is a way to manage healthcare costs by taking care of free forms. And that was proven in La Crosse, Wisconsin. This town decided they would have the conversation. Some activists got together with their faith, their business, their medical community, and they said, we're going to raise this rate of completion of advanced directives. And they did. And you can look these articles up to about 98%. Two things happened. One, when people talked about end of life care, there was something that bonded them because they started looking at everybody a little bit differently. We're all mortal and we have more things in common than we do that separate us. So that kind of changed a subtle dynamic in the way people interacted. And the other thing is they reduced their healthcare costs by a third. Pretty impressive. So where do you get advanced directives? Many sources. I personally like mydirectives.com. I've looked at all of them. I think it's the most complete and the best. It's free, it's online. Here's my advanced directive on a QR form. I carry this with me wherever I go. You'll see that in a second. And it also connects electronically, so it's in generally speaking, working towards being in a medical record so that it's found when you need to have it. And also, you can adjust it any time. I mean, you can go online, just name and password and change it. ARP has a good one. There's faith-based, if that's important to you. Here's another one, MimiRx. So there's lots of sources. The challenge is only you can complete yours, not anybody else. Only you get to complete your advanced directive. But you got to, do it. You got to sit down and do the paperwork. It doesn't take long. You have to think about it, but it takes about 20 minutes. And here's what it looks like, and it's on the phone as well. So, Steve, before I jump into part 3 here, anything that you want to share from the crowd?
Let me take a glance. Okay. Matt asks, do you see a path where people have to complete an advanced directive to receive Medicare benefits? Oh, but man, you'd be the person to ask that question. Yeah. What about tying advanced directives to some kind of entitlement?
First of all, I don't call Medicare an entitlement because we paid taxes for it. So
Okay.
That's not quite the term that I would apply to that, but that's okay. That's a great question, Matt. And I tried to do that at the state level, but it was just politically impossible. It's kind of a crazy story. I'll try and see if I can do it in 1 minute or less here, but I'm a pro-choice Democrat. I partnered with a pro-life, so to speak, Republican, and we came together on this issue, and nobody liked it from the far left to the far right. I thought it was just empowering people who are poor to be able to have these forms, because a lot of us come to this because we have some, I got married, we bought our first house, we had a little bit of income, it was time to start thinking about those things. He got kind of pillaged from the other side about being accused of pulling the plug. I think it should be part of a requirement, in the sense that you would say you have to complete an advanced directive form, or you have to actively decline to complete one. But at least it should be included when you apply for anything in government benefits or healthcare. So I would agree with that portion of it, that people should have the right to decline if they don't want to. But as we showed in our study, most people want to do that, want to have this. And another thing we asked folks is, where do you want to get the information about your advanced directive? And most people said their clinician. We gave them other choices: attorneys, faith-based, and so on. So people want to have these conversations with their doctors, or their nurse practitioners, or whoever. But too often, clinicians don't have the time or are reluctant to bring this up because we've been acculturated not to talk about this topic.
Okay, and I don't want to derail the conversation, but this is a really good question here because it's going to help somebody out. And they say, my sister is very sick, but she's on dialysis. And if she decides on hospice care, they won't give that to her. And she thinks that is, in her words, like suicide. Is there any way to give hospice care and continue dialysis?
That's a really good question, and I'm not sure I know the answer, because it depends who the clinicians are and how they're making those decisions. So my gut feeling on this is, if you're on dialysis, generally they're not going to let you be qualified for hospice, but I think you could continue on and just go for hospice when you get a little closer to the end. But I don't want to really try to give specific advice in this particular case.
Okay.
Great question.
Oh, yeah. And
a lot of the issues involved in this, because we're so averse to having these discussions historically, is that a lot of the details have not been worked out as well as they should. You complete your advance directive, don't put it in a safety deposit box. It has to be available, but they're not yet really made available. We were able to pass legislation in Maryland last year, actually a bill I put in before I left the legislature, but it passed in 2022, creating an advance directive electronic registry. So it's available throughout our state's health information exchange. So whatever hospital you're in, but what if I'm in Maryland and I'm traveling to California, or you go to Iowa, what happens then? These are all questions that have to be worked out. A lot of this kind of change happens when people start completing their advanced directives and they're made available. And then clinicians need to learn to honor them. But it starts with us, responsibilities here.
Okay. Well, we got a pile of questions, Dan, so I'll let you get through your slide deck, and then
great. I love the
then we
questions.
can just take care of the questions.
So topic we often don't talk about, organ donation, body disposition at the end. So I'm all for organ donation. I revamped the organ donation laws in Maryland, and it made a huge positive difference. We still have a long way to go nationally, but I remember the hearing very clearly. It was very moving, but especially one thing always stayed out of my mind. There was two people up there. One was the family member of a donor who donated a heart, and the person sitting next to them was the person in whose body that heart was beating. That was profound. And so I'm all in for organ donation. But let's move on to the other choices. Medical donation, medical school donation is excellent. It's no cost, but you have to arrange it in advance. That's how all of us clinicians learned anatomy. And so that's a perfectly fine choice. Many people choose that as well. But most of us do one of the more traditional methods of burial or cremation. And I want to talk a little bit about those because you won't hear this elsewhere. This is the standard typical cemetery. And next time you're driving by, take a close look at it, pause and take a look. And some have more elaborate monuments than this. I never liked this from a couple of points of view, and here I'm going to editorialize. One is that I think we're all equal in death, but the size of the monument, implies that you're more loved or have more money or something. And humans have kind of been involved in monument building. But also, this is what's buried there. Let's think of all the cement and wood and metal that is buried in this, not to be used. But we humans have had a history of building monuments to the dead, and there we are. But this is a lot of stuff there. And I'd rather not have all that resource and pay for all that resource just to put me in a vault in the ground. Some people choose cremation, but that's a big carbon footprint. You got to heat the body up to 1900 degrees for 2 to 3 hours. Stuff is released, into the air. We have enough air pollution problems as it is. So what's the alternative to this? Natural burial, green burial. This is a movement it's really going back to what people used to do all the time. And think in this country, maybe kind of a mythic example, but somebody died in the house, family, the clinician couldn't do much, but knew the family well. The person was laid out in the parlor and then taken out into the family graveyard in the back and buried there. This is a return to that. It's not new. It's really going away from what has been. What's new is the funeral industry and the cemetery industry, the way we have it. This is the old way of doing things. And I've been to some of these natural burial, green burial cemeteries, and it's just burying somebody in a plain coffin or a shroud of some kind. It's also way less expensive. And this is what a natural burial cemetery looks like. This is actually Ramsey Creek, South Carolina. Family inherited 300 acres of land. They had to do something to make money. There was pressures on them to put a housing tract in or industry or whatever. They didn't want to do that, but they had taxes and upkeep and insurance and so forth. And so they created a natural burial cemetery, and it looks like a park. And there's benches and there's trails and there's a non-denominational chapel. And every so often when you walk along, you come across a little flat river stone. Very simple. They're GPS, so you can always locate the person. For my taste, this is much more the kind of place I would rather go to if I wanted to think about a loved one or contemplate the life of somebody I loved that was gone. And so these are coming. We have one in Maryland now, but they're coming one in a couple of areas, and they're coming around the country, actually. So to check out natural burial if that appeals to you. It appeals to me. Dust to dust, earth to earth. Now, there's some other issues here that I'm going to run through a couple of them. One is what doctors want for themselves. It's really interesting. Actually, there's been surveys on this, and most doctors are off in these areas doing things to patients that they personally wouldn't want for themselves. So what I would suggest to you, whenever you're thinking about a medical procedure, if the doctor is recommending it, say, Doc, if you were me, or if I was a loved one, would you have this done? That's a really good question, because too often there's this disconnect, and that really troubles me. The minority health and diversity perspectives. Minority communities have been somewhat ignored or pushed around by the healthcare system. This is empowerment for anybody. Take advantage. This is a way for filling out free forms. You can do that. Let me touch on the last one because it's always controversial down here, assisted dying. That's one version or another of physicians helping or people getting medicines that allow them to take them for themselves. I heard this issue when I was in the state legislature a lot, and there are people very strongly for and very strongly against. And I thought all the people who spoke were sincere. They were passionate and honest and sincere about their views. But a lot of what they talked about were things that could have been managed. What they were worried about could have been managed if they completed advanced directives. And most of them hadn't. And I always asked them, have you completed advanced directive? Look, you get a lot more juice with a cocktail party talking about what is the ethical issue of a physician giving a prescription to somebody who would then take it and die. That's a great cocktail party conversation, as opposed to, have you completed free legal paperwork that's been around since 1991? Doesn't get the juices flowing, but that would address almost all the things that people are worried about. In the end, I thought the bill was well crafted. I would have voted for it because there's always some outliers. None of this is guarantees. It's all about shifting likelihoods to your own values. And so all these things can be dealt with. And the dementia issue, the silver tsunami that's coming, boy, we got to figure out better ways to deal with that. And the spiritual practices and rituals, you can be very creative according to your own values, whether they're traditional or non-traditional, how you want to approach it, and make this a meaningful experience for your family. Yeah, well, some people, they're not happy that clinicians have ignored their wishes. And this is a series of slides that I'll run through here, but if you're in the legal community, pay attention. I dealt with plaintiffs' attorneys, trial attorneys, people who sue doctors in the legislature a lot, and I have a healthy respect for them. I actually miraculously never got sued in my entire clinical career, which is pretty amazing for approximately 160,000 patient encounters, not to mention other things. But wrongful death is you went to the hospital and you weren't supposed to die, but you did. This is wrongful life where your wishes were ignored. And this comes up a lot. And this is a classic case right here. This woman, and you can look these up, went to the hospital short of breath, had a pleural effusion, that's fluid in her lung. They tapped it was cancerous. She said, and she and her granddaughter agreed, we don't want any heroic efforts. But they did. And they went ahead and ignored her wishes, and they sued and won $1 million. This is coming up more and more. Here's another case from California. So I'm not going to run through the details here. You can scan this, but this is something that my generation, baby boom generation, wants things their own way. And if they don't get it, they're going to potentially have litigation. And when I speak to clinicians, they say, you don't want to be sued for this. I have added this to my advanced directive. It's not in the book. But I went online to mydirectives.com and said, and I added this. I want my advanced directives followed. And if they're not, legal action or move me, one or the other. But I don't want to be subject to things that I don't want. And some hospitals may or not be, or some states may not be willing to do what you want. There may be options. I'll just touch briefly. Also, if you're a clinician, you can get paid. It used to be you couldn't get paid for having these discussions with patients. It turns out you can. You have to document properly. So I have my primary care doctor. She's great. And every so often we have a conversation. I visit. I'm pretty reasonably healthy. But there's not that much time for us to have this kind of conversation. I'm involved in this, so I understand it. But when I talk to her, she says, boy, it's hard to get 30 minutes to have this discussion, and often one discussion won't do it. But we know that people want to talk to their clinicians. We passed some bills to fix this. So this is what I'm going to ask all of you to do, if this makes sense, and we'll go through some more Q&A on this topic. But National Healthcare Decisions Day comes every April 16th. That's pretty recently. It's tied, of course, to April 15th, another day that none of us forget. Death and taxes, taxes and death. So, plan ahead. This is going to take time. Nothing happens fast. And I'll share an anecdote from my legislative life. Back in 1995 was my first legislative session. There I was, a newbie, a freshman legislator, very excited to be there. And there was a bill. I couldn't walk down the hall to get both sides, opposite sides of an issue, coming up to me. And the people come up to me and say, Delegate Morhaim, you got to vote for this bill. It's the most important bill this year. And then I'd walk down the hall, and someone came to me and said, Delegate Morhaim, you got to vote against this bill. It's a disaster. It'll destroy the Maryland economy. What was the bill? It was to ban smoking in restaurants. Well, that was not controversial now. It was really controversial then. It took 10 years in our state to ban smoking in bars. Nobody could introduce a bill to reintroduce smoking in restaurants these days and be a political survivor. And so I've seen things, kids in safety seats, wearing seat belts, all kinds of other stuff that was very controversial or difficult. Years, women's right to vote started in 1848. Women didn't get to vote till 1919. I mean, these things take time. So we have to be, all of us individually, the leaders to make this happen. And social workers, chaplain staff, everybody can do it. So, I complete my advance directive, and when I bump into people at the gym or the grocery store or on the street or something, we're chatting, I'll say, by the way, have you completed yours? A lot of times they run the other direction or think I'm strange. That's okay. A lot of them come back to me weeks or months later and say, thank you for bringing it up. It took me some time to get to that idea. And it took time for me too. So this is what gives life meaning. So I want you to be the one to bring this up to others. Let me close with a story that changed my life on this. I was working a 4 to midnight shift. We got a call. Little old lady found on floor, LOLFOF, sorry for the ER jargon. And the ambulance call, she clearly had a major neurological complication. This was a typical demographic, older woman living alone, doing fine until this happened. And so when she arrived, it was clear immediately that she had a major neurological catastrophe. And I did all the stuff that we do. And at the same time, calls went out to the family. And they began to dribble in bit by bit. And I had them in the family room. And I'm shuttling back and forth over the few hours. We're getting the appropriate consultations and everything, and CAT scan and workup and this and that. And I'm keeping them informed as best I can. But what I see where the family gets together, there's a lot of conflict and crisis going on, and it gets very emotional. And sometimes it happens when families get together, whether it's a stressful situation like this or Thanksgiving or a wedding. I mean, just the wounds and things came out, and people are screaming and yelling, and some people are crying, and some people are sobbing, and it's a whole scene. But finally, the final diagnosis is she has a massive intracranial hemorrhage. There's no hope of recovery. And I get a copy of, she's brought an advance directive. Someone obtained it and gave it to me, and I read it, and it says, if I'm an extremist, no hope of recovery, no hope of meaningful life, no heroic efforts. So I go in the room, everybody's just breaking down, one person just staring in the corner quietly, other people are screaming and yelling. And finally, they all calmed down. It's time for the doctor to say something. And I said, look, I appreciate all the input, but this is like she's talking to me. If she could talk to me, I would do what she requests. And this is the living document that tells me what she wants. And it's very clear. So I'm going to go in the room and I'm going to take the tube out of the windpipe, stop the medicines that are keeping her blood pressure up and her heart beating. And you can come in there with me. And you might think at that moment, everybody would get more hysterical. The opposite happens. Everybody calms down. Deep breath. She removed the burden of this difficult decision from her family. They came in the room with me. I disconnected everything. I dropped to the back of the room and watched the family come together at the head of the bed. They held her hand, stroked her brow, sang some songs, said some prayers, whatever, whispered messages in her ear. And it was a very quiet goodbye, and she died quietly within an hour. And I realized this woman, changed my life, actually. It launched me on the trajectory that brought me here. But what I saw was that she did this for her family. We're a very me-oriented culture. It's all about me, me, me. But you're going to take care of this so that your family isn't left in the lurch. You may know of, and I've certainly seen families that this didn't happen, and the family carries this bitterness or disagreement. 3 siblings, one let my grandma die in peace, and others said, do everything for her, and some are in the middle. I mean, this is normal human dynamics. But when the decisions have been made by the person, it relieves the conflict for the others. So the reason to take care of this is not just for you, it's for the people you say you love. If you love them, you'll complete your advance directive. So break the ice, start the conversation. And there's the book, and I'm available for talks, presentations. Steve, questions, comments, personal attacks? Whatever.
Oh, no, we got lots and lots of questions, but I'm going to start with the first because I need this too, is can you send me this PowerPoint so I can drop the
Certainly.
The links into the recording, and that'll
No
make it
problem.
easier for people to access. I threw a few into chat, but that'll be helpful. So just send that after the call, and then it usually takes a couple of hours, folks, but I'll have it up at proaging.com. Okay, so let me jump into the Q&A, then I'll go through the chat. And if any of you all need to jump off early, don't worry, you can jump back on and hear the recording and what have you. The first question, and I always love it when people are sharing a personal story that we can potentially help them with. But this woman says, my husband tried to get hospice care, but was not eligible because he wanted to continue the one thing that made him feel good, blood transfusions. I was able to get him to the infusion center, so he could not have the hospice care. If he had, he would have not had to go through having police medical examiner involved when he fell to his death suddenly in the bathroom. I live in DC. A friend of mine who lives in Maryland and whose husband had the same diagnosis as mine also fell and died in the bathroom. He was getting transfusions but did not have hospice care. And so long and short is that why do transfusions prevent folks from being hospice eligible, and that it would help make things easier for folks?
I guess the answer is because that's the way the rules were written. I agree with both those cases that it shouldn't. So I think hospice care rules need to be rethought, and that's up to us to let our federal legislators know. You know, the averseness to having conversations about the complicated details of this is so profound that people don't want to look at it. But those are two examples right now, and the other one actually from the previous call, where we should change some of the rules or rethink them at this point.
And when you say people, I mean, in this case, you're referring to legislators and policy makers, correct?
Absolutely.
Yeah.
But those are great stories. And I can tell you from being in the legislature, I responded especially to those kinds of stories and the people who came to testify. The organ donation bill example, that was very persuasive for a lot of folks who had, my fellow legislators who had a lot of questions and heebie-jeebies and all kinds of anxieties about it. You know, that was so compelling, and some of the other people were so compelling, it enabled them to get over the hump. And then we had to work out a lot of the details, to be sure. It wasn't like simple, but it got people aware and in tune why this was important.
Okay. And Kristen Newton says, is there an age limit for donating your organs? Tie it in with what you just brought up. My husband died in 2016 and his donation was declined, which was extremely offensive and hurtful to him. That I've never heard of that, Krista. Dr. Morhaim, are you aware of this? I was not aware of this.
Here's my experience with this. So no, I'm not aware that there's an age limit. What should be happening is that if the death is sudden, like in an emergency room, we call Donate Life Maryland, and every state has its organ donation procurement program. Experts come in and then they would look at each person. If they're dying in an intensive care unit in a different situation, where they may be more likely to be heart and lung donors, they would assess each person individually and make a decision. I'm not aware that there's a specific age limit, because even tissues like skin and bone and tendon may be valuable in a senior citizen, whereas their kidneys may not. So it takes a real set a specialist who understands all the rules of organ donation, what's possible and what's ruled out. If it was just done on age, I don't get that part.
Yeah.
But maybe other reasons, and they said that for one reason or another. But you have to look at the clinical chart in depth. Did they have any kind of communicable disease or things that would be concern and what might be eligible? For my advance rate says take whatever, and I hope it helps somebody.
Okay. I'm sorry that your husband went through that. Chris. Okay, let's see. Joanne says Medicare pays for this in wellness visits. It's a revenue source for hospitals. Why are they so opposed to having these conversations with their patients? Are we training new providers to deal with this? And I'm not sure where in the discussion that question came, but I think you probably know what she's relating to.
I'll try. I don't want to project too much because I didn't quite understand that question either. But there is that tendency in institutions to keep people going for treatment that they didn't need or want because the institution gets to bill and pay for it. And that's another reason why individual empowerment is so important. And we're all on a learning curve about this, including me. So you have to be able to stand up and say, no, this is not what I want, or this is not what the advance directive says. And that's the wrongful life lawsuits. That is motivating hospitals now a bit more than they did, because people are saying you didn't look for the advance directive, you got it and you didn't read it, you read it and you didn't honor it. That's not right. This is a legal document. They've been around since 1991. They're in every state. Now, there are a lot of different issues. You might be, living in North Carolina and you're visiting your cousin in Montana. When something happens, what are they going to do? And some states require notaries, only a few, but most of these you can do it at home. You don't need a lawyer. You don't need anything. That's why I like mydirectives.com. It's free to individual people. They work with systems. That's how they get paid, but they make it free to individual people.
Well,
and then you can change it.
It's almost like you're queuing up these questions with your. You're very good. This must be something you learned in the political world there. But John says, I asked my directives to share my document with my primary care physician. The primary care physician's policy is to not open links from external sources. He asked that I print a copy or send it to him in a PDF. Because the document is a living one and changes from time to time, I don't trust myself to remember to share the updated copy with the physician, and I didn't want him operating from the old copy. So I responded that my wife and kids would have copies and could share with him if it becomes relevant. Do you have any suggestions here?
Yeah, I think you should talk to your physician about accepting these as legal documents, because they are. You do have to change them
via email.
But if you have to print it out, it's not like you change them all the time. In fact, one of the things I like about my directives is every year or two, they send you a little reminder. And I'll confess, I had someone listed in my way down the decision tree, if no one else was around, who had since passed. I had a wonderful sister-in-law who I loved and trusted, and she had passed. And there she was in my advance directive. They sent me the reminder, and I hadn't looked at my advance directive in a while. And, I took her off the list. Also, as your spiritual values, relationships, health changes, you're going to want to update it. But, I just, if necessary, and you really like your doctor otherwise, print it out and just keep handing them in every 6 months or year as you update your advance directive. But in most places now, they're being integrated slowly into health information exchanges. And that's what needs to happen. We're a mobile society. Right. And if somebody came to the emergency room from Pennsylvania or from South Carolina, don't say, oh, well, I'll look at your EKG and your blood test result, but I'm not going to deal with your advanced directives. Wow, that doesn't make any sense.
No. Okay, so someone says, so who can complete an advance directive and health insurance pay to provide coverage? Can licensed social workers provide this care?
Well, only you complete your own advance directive, or any adult over the age of 18, completes their own advance directive. So you can talk to anybody you want about it, your next door neighbor, social worker, clinician, whatever, about some of the choices. Another thing I like about my directives is it has a little hot link. So it says, are you interested in dialysis? You can click on dialysis if you're not entirely sure what that is, and then it explains what it is. So there's a lot of ways to deal with it. Also, if you choose another kind of advanced directive, you can upload it into the My Directive system. So there's Catholic, Protestant versions, Jewish versions, Muslim versions. So if you like one of those that are consistent with your faith values, you can load that into that system.
Great. Jackie asks, can Dr. Morhaim comment on elder abuse and how it intersects the drafting of advanced directives and powers of attorney? And shouldn't people have attorneys draft their powers of attorneys?
Well, powers of attorney, yeah, your attorney should draft. That's different. That's more on the estate planning side, what you do with your house and your valuables and your bank accounts. This is personal medical. You can certainly consult with an attorney, but you don't need an attorney. And in fact, that's one of the great things about these forms. They're free and you can just do them. There's another form that I didn't touch on called medical orders for life-sustaining treatment. It's called some places are MOLST or PULST physician orders. And those are actual orders where the clinician will sit down with the patient and go through more detailed stuff. An advanced directive is kind of just general guidelines and choosing a surrogate decision maker, whereas these are specific details that you would, for your unique condition, would you want this kind of procedure that may be applicable or not?
Yeah, and I think one of the things, and this may be where Jackie's going with this, is that we know that a lot of elder abuse is committed by family members to their family members, which just really begs for all of us to really take a hard look at those people that in our families, blood related or not, that have the same value system and that, can properly execute our wishes if the time comes.
I think you're right, and I thank her for that point. This is all the more reason to do this while you're awake, alert, oriented, and capable. Don't wait until things are bad. Look, I get a call from a family member. They're not doing well. I get unnerved, and I'm an ER doctor. I mean, I've dealt with all kinds of stuff, and yet emotionally, I get a little unglued too. So you want to do this when you're calm and centered. That's the whole advanced portion of advanced directive. Then the directive is, this is kind of what I want. And again, you can fill in a lot of details in there. You don't have to just follow the forms. So I gave some examples personally, but you can free text. If I'm in this condition, my neck is broken, but my head is working, keep me going. Or you could say, I don't want to live that way if I get really sick. I want 3 tries at cancer cure, but if not, that's enough. Some people say, I want all the cancer cures possible. These are individual decisions, but that's, we're a culture that celebrates and values individual decision-making. Yet in this area, we've collectively abdicated. Yeah, and that doesn't make sense.
Going back to Krista, she's the person in the audience that shared about her husband and the organ donation. She did follow up and said he was 81 years old and he died of glioblastoma.
It's a brain cancer, and apart from anything else that may have happened, he should have been. I mean, my rough guess, I don't want to commit to anything medical here, but he should have been considered a candidate. And it may depend on the state where you have. Different states have more robust organ donation programs. So as the lead sponsor of the one in Maryland, 2008, I'm very comfortable with what we're doing here, but I certainly can't say that I'm aware of everything in every state and how it operates. And like all things, you may get an individual person that just is not, as effective as others, and that happens in everything in life.
And Dr. Morhaim, we got about 3 minutes to the top of the hour. Still got a bunch of questions to get through. Can you hang on for a little bit longer?
I can hang on. I'm happy to. This is important, and I want people to feel free to talk. So go ahead.
And just a reminder, folks, if you jump off, this is recorded. I'm going to get the PowerPoint, and I'll copy all those links into the chat too.
This is not a topic that you can all cover in 45 minutes. No. That's why I wrote. That's why I wrote this book.
I love these questions, folks. This is great. And
that's why this book exists.
This is one that I actually have here, a question, but audience member says, if you already have a lawyer write your advanced directives, does it confuse things by adding additional documents like My Directives to your directives?
Well, a lawyer doesn't write the advanced directive. They may give you the forms, but you complete it. You can certainly discuss it with your lawyer, but my sense is that most lawyers actually are not that amenable to this. They deal with estates. But I did have a friend who was a high-powered attorney in Los Angeles who had some very impressive clients, and they dealt with all these big things and big money issues. And then she'd say, you ought to complete this advanced directive form, and they just kind of shuffled it to the side because they don't want to think about death and dying and all that stuff that we all freak out about. So she bought copies of the book and gave it to them for free. two things happened. One, they were astonished that a lawyer gave them something for free. That was nice. She bought it in bulk and put a sticker on, gift of the office. Instead of giving them a fruit basket, she gave them this. And they would come back a few weeks later and say, thank you for giving me the book. I read it, and now my questions are answered. It actually brought her more business. I'll give you one other anecdote. I had a friend, 5 siblings in their 50s, and the parents were in their 80s, and they had trouble, having these discussions. He got the book, gave it to everybody as a holiday present. They all read it, and then they came together and had this discussion. And in my own family, our 3 adult children, they came home from where they were living, and I brought out advanced directives, and we all recompleted them, and then we watched a football game together. So, we had friends come over and do the witnessing. It's not that big a deal once you get into it. You just kind of mentally over the hump.
Yeah.
And it doesn't guarantee things. I want to be real clear. This is shifting likelihoods, enabling and empowering in a situation otherwise where chaos ensues, and committees will make decisions. People you don't know will make decisions. Families will be in conflict. Doesn't mean those things can't happen, but you're reducing their likelihood tremendously. Just like that closing story where this family was in conflict and they went away together.
Yep. Okay, let's see. Arthur says, sometimes it's the doctors who want to try just one more thing that could somehow make a difference, and the family knows there's no chance. I mean, I've heard stories like this.
Oh, sure.
Your thoughts on things like that, Dr. Morhaim?
Yeah, unfortunately, I've worked with some doctors, especially when I was in medical training and had to follow orders and I write about this in the book, kind of flogged patients long past hope of recovery that the rest of us knew was the end. I think this is where you have to ask the doctor the question that I asked. Doc, if this was you, would you want this done for yourself? If this patient, my mother, was your mother, would you add this additional treatment? And if they say yes, then you can consider it. But you always have the right to say no.
One of those, remember that question that I asked a little bit earlier, and it was, I think I misread it or what have you. The person says, no, you misunderstood the question. You
okay,
said,
good. Let's clarify.
You said health insurance would provide coverage for completion of advanced directive.
I misspoke if I said that.
Then insert into medical records.
Okay, if I said that health insurance doesn't cover completion of advanced directives, and nor does it cover putting it into a electronic system. So if I said that, I didn't mean to say that. What I do mean to say is that health insurance costs will go down if people complete advanced directive, presumably because most people do not choose everything, and most people do not choose do nothing. Most people choose a middle path. And every death that doesn't happen in an intensive care unit but happens in the hospital, or doesn't happen in a hospital, happens in a hospice, or happens at home, there's a huge reduction in cost. So the system then saves money that way, but people have a more holistic, family-centered experience too. There's nothing wrong about being present when somebody dies. We all fear it, but we've palmed that off to other folks. It happens. It used to happen a lot in our cultures. It doesn't happen very much now, but I've talked to families and been present once and personally, but other times around families where the person who was dying died quietly at home, and it was a completely different experience than a high-tech death in a hospital. Okay, now here's an interesting one, and we may need a lawyer, but I'm not sure here. It's Richard asks, if someone with an advanced directive can no longer make decisions, but has a power of attorney giving authority to another person, how can changes in the advanced directive be made? They can't at that point. That's why you have to update your advance directive. Clinical situations may dictate something different, but you can't change the advance directive because only the person who completed it can change it. Yeah. So, okay. No, that's really good to clarify that. Jeannie says, my employer had a speaker come in this week from Gilchrist Cares in Maryland to speak about advanced care planning. This is what needs to happen, Jeannie. And unfortunately, a lot of employers are doing their best, inviting providers to come in, but I'm willing to bet that those are a lot less attended than the getting your kid into an elite private school, sessions. But we just gotta come back to our desk and start talking about it to our coworkers. Hey, listen, first of all, Gilchrist, I know it's a great organization because it's here in Maryland. But the other thing is, look, Again, I was running for office. I was asking people to vote for me, and I was willing to talk about end-of-life care. And it actually, people appreciated that someone brought it up. I know it's a hard topic. It was hard for people to talk about a kid with ADHD. It's hard to talk about a family member with an addiction problem. It's hard for women to talk about breast cancer, men to talk about their prostate cancer. I mean, but these are all realities. And not talking about them is worse than talking about them.
It is.
Once you learn. Now, some people will just say they're not going to get it. But this isn't stuff that I absorbed all at once in 1 minute. This was a process over several years. I was doing codes on people that I didn't know, didn't feel like we wanted to be doing the codes. I was talking to families, and all kind of, I had that experience with that one patient that I described, and I thought, this is a way, and I understand it's going to take time, and that's why I've committed a lot of my passion and energy and time to this, and wrote these books. Fortunately, that's but this is a work in progress.
Yeah.
Just like banning smoking in restaurants was a big fight. Do you drive your car without a seatbelt now? No, this is like wearing a seatbelt.
Yeah.
You may be in some accents, a seatbelt won't make a difference. And you could probably drive without a seatbelt and be okay. But basically, a seatbelt is a safety net that's going to reduce a lot of trauma. And having worked in a trauma center for 25 years, seatbelt makes a huge difference.
Oh, yeah.
When I started as an ER doctor, kids weren't strapped in. I saw some horrible car accidents involving children. Since kids are strapped in baby seats, it just doesn't happen anymore. So this is think of advanced directive as this is an airbag and a seatbelt for end-of-life care. That's what this is. Not a guarantee. It's going to increase your statistical likelihood of a better outcome.
Okay. Now, somebody put in here, advanced directive decision tree, list for people with advanced directives. I did a quick Google search. Are you familiar with advanced directive decision tree?
I'm not sure in that particular context. I tried to break it down and, who do you choose? How much care do you want? And body disposition. Then each one of those has choices. Maybe that's what they mean. I'm not sure.
Yeah. So, but I did a Google search. I saw some interesting stuff on there. Okay. So let me get to some of these chat questions. Adele says
37. I'm 37 in the chat and 5 Q&A.
Lots of questions here.
And it's good. This is why we have to have these discussions.
Yeah.
Lots of questions is good.
Adele says, do you work with end-of-life doulas?
I think end-of-life doulas are great. I personally don't do that work, so it's not relevant to me. But yes, I think end-of-life doulas do an excellent job, and I write about them in the book. And I think they should. I like birth doulas and end-of-life doulas.
Oh man, Jennifer Brown, thank you for this question. It's great to ask a former politician, elected official, a question like this. Do you think in today's political climate, could legislation be passed requiring seatbelts?
In some states, yes.
Oh man, we got to have fun, folks. Thanks.
Yeah, that's fine,
Jennifer. What is the health insurance? What the health insurance will cover is the advanced directive conversation with your primary care physician. This is a good use of the Medicare wellness visit. Okay. I think that's maybe some of the dialogue that we've been having about paying for is that, yes, this is something, and ideally it's the doctor, especially a Medicare doctor, is the doctor that is starting the advanced care conversation.
Absolutely. The doctor should be initiating this discussion. And I understand the pressure that a lot of my colleagues who do this, who do geriatric care, Medicare, or any general practice and have, trying to squeeze a conversation like this in a 15 or 20 minute allotted visit. But they can bill for it. This is a spin-off of the crazed and completely, baseless death panel discussion. It used to be that Medicare would pay doctors to have discussions with people if they were already declared to be in the last 6 months of life. And all that bill did, the first part of that Obamacare bill, said you could have that discussion with any Medicare patient. That morphed into this crazy death panel. I actually read that section of the bill. That's all it did. And I'll be a little political here. The Republicans who all voted for the prior arrangement, that is, you could have the conversation and get billed if they were dying, voted against and blocked the have it when people are well and in Medicare. It took a bunch of years, and then it did get applied. but it may take more than one or two conversations. This is not a thing like do you like cream or sugar in your coffee? This is something that requires some thought. And so the earlier you get into it, the more you study it, read the book, read other resources, try and get 5 minutes of your doctor's time and then do it again, or say, can we make a special appointment? We can have this call or a video call on this because you don't need to be there physically. I have these questions, educate yourself, and then you're more in charge.
Now, Leslie has a very thought-provoking question: is what have you said to patients who are totally conscious and dying only with you around? Have you prepared to guide a patient beyond his death into the light? Like, have you played that role with anyone?
A few times, but I'm never alone in an emergency room. There's always nurses and other doctors and family, almost always family members. But when I really see that somebody is, imminently approaching death, like in the next 5 or 10 minutes, I do my best in every way possible to provide support and comfort, both clinical and personal.
And as an aside to that question or comment, I want to throw up your I'm gonna pull up your table of contents to your book, and the first chapter is chapter 1. It says, "My dog got better care than my mother."
Yeah,
and
it does.
and I just, to share a personal reflection, the most amazing death that I personally experienced was when my dog needed to be put down. It was the most beautiful, peaceful thing, and my wife and I were so scared, and it was just an amazing experience. And I said to the vet, I go, "I can't believe this," and she goes, "That's what everybody says, is that and I think this is not any kind of endorsement of medical aid in dying or assisted suicide, but sort of talking about, like, it was just a positive experience, the way that we were prepared for my dog to pass away. And it was just this beautiful experience where my wife, myself, and the vet were all hugging our dog, and she peacefully went on.
Yeah, we went through that with our dogs too. But that quote is exactly from what a lot of people would say at my talks. They'd raise their hand and say, my pet got better care than I did. And you go, okay, why can't we get at least something better for the people too? Whatever it is. I understand there are differences in many respects. We all get that, but we can shift the likelihood to that. And I got to go in a minute now. Sorry, but
and we're going to wrap things up. How about we do this? Let's finish on this last topic, but I'm going to invite Dr. Morhaim back, and this is.
We can just do an all Q&A.
Yeah, exactly. Actually, that's not a bad idea. We'll just
fine.
Kind of they have these death cafes, and it's sure. Great idea. Matt says, this may sound odd, but what's the best state to die in? In other words, what state has the best laws for dying? You have your own choices. And
Oregon's pretty good. Maryland's pretty good. They're all somewhat different. I actually have somebody banging on my front door. Sorry to be difficult, but
let's take off.
Love to stay.
This has been awesome. Dr. Morhaim, thank you, everybody. Catch the recording. Talk to you all soon.
Thank you, and I'd love to come back. Thank you, Steve. Thank you, everybody.